DSM-III Personality Disorders, Diagnosis and Treatment, by Alan Francis, M.D., Professor of Psychiatry, Cornell University Medical College, and co-editor of the journal Personality Disorders. This is the third cassette in a 4-tape program. It is published by BMA Audio Cassettes, a division of Guilford Publications Incorporated, New York, New York.
Now let's discuss the borderline personality disorder. Actually, this has been the most studied of all of the personality disorders, even though it's a new category that was introduced for the very first time in DSM-III. It's not clear why it's received so much attention. It may be because borderline patients suffer and cause suffering, and often do both of these in a way that's dramatically flamboyant. Moreover, this is a very common personality disorder, usually the most frequent or perhaps the second most frequent in patient samples, whether these are derived in inpatient or outpatient settings. A third possibility for the popularity of research and discussion in this area is the fact that the borderline personality disorder overlaps with all sorts of Axis I and Axis II conditions, making it a particularly interesting area for study for descriptive psychiatrists. Psychoanalysts are also very interested in the borderline personality disorder because of hypotheses that it represents a level of intrapsychic structure, of integration and differentiation, that's halfway between the psychotic level of structure and the neurotic level of structure. Finally, it's at least possible that the borderline personality disorder has become a popular diagnosis because it's a convenient waste paper basket category for all sorts of patients who present difficulties in treatment and in diagnosis, and for whom more specific diagnostic or treatment statements cannot be made. The DSM-III definition of borderline personality disorder includes a number of items that in various ways tap instability. Instability in identity, in affect control, in impulse control, in interpersonal relationships, and in behaviors. In fact, the syndrome was originally described by psychoanalysts, who noted that certain patients who appeared to be just fine at initial interview were particularly prone to treatment failure. Patients who meet the DSM-III borderline personality disorder criteria will suffer and cause suffering not only in their lives but also within the treatment relationship. So wherever you go, people are asking, how can we treat borderline personality disorder? There are, of course, no simple answers to this question. First off, certain tips on interviewing the borderline personality disorder patient. There are several different types of typical presentation. Some patients will appear almost completely normal in the initial consultation. The evaluator will be surprised to hear that outside of the consultation situation, all sorts of terrible things, wrist slashings, chaotic love relationships, impulsive gambling, all sorts of things are happening, as if the patient presenting before one couldn't possibly be the same person who describes these other activities. Another typical presentation, however, will be one in which the patient is remarkably regressed within the consultation situation, acting in a way that's childish, impulsive, demanding, entitled, manipulative, trying to get the therapist to provide direct help in what appears to the patient to be a terrible life emergency. As a rule of thumb, it is wise for the clinician to keep in mind in interviewing the borderline patient that these individuals are often regressed enough, both in their outside lives and often also in their treatment presentation. A non-regressive treatment, one that presents clearly to the patient the expectations and demands of the situation, the fact that they have to act in certain ways to avoid serious consequences, is often most indicated. Letting the patient know that the current troubles are temporary, that the patient is likely to experience them in a very different way if only they manage to survive over the short haul, is quite helpful. Borderline patients often respond well to being told that what they have is a problem in growing up, and that time is on their side so long as they don't do irrevocable damage to themselves. These are patients who tend to get overly involved with therapists. At times, therapists tend to get overly involved with these patients, either in a positive kind of rescuing way or in an angry, rejecting, and self-protective way. It's wise for the therapist not to feel responsible for the patient's behavior or for the patient's life, taking a neutral position is often difficult, but also possible if the therapist does not have grandiose fantasies of being able to rescue the patient. What can we say about treatment? Well, first off, many medications have been tried. And these include monoamine oxidase inhibitors, neuroleptics, lithium, stimulants even for patients who present with attention deficit syndromes as well as the borderline personality disorder. It's hard to know which of these medications, if any, will be effective in any given clinical situation. The choice of medication must depend on the presence of a target symptom beyond the symptoms that are included in the DSM-III Personality Disorder lineup for borderline personality disorder. In other words, if a patient presents with cyclothymia, thought disorder, attention deficit, or depression, it may be useful to address any one of these symptom complexes with a medicine. But to expect that the medicine by itself will cure the problems of the borderline personality disorder is to expect too much from that medicine. So that primarily we'll be treating the Axis 1 condition that overlaps with the borderline personality disorder rather than the borderline personality disorder when medication is prescribed. There are no control studies on group therapy for borderline personality disorder patients, but many clinical discussions indicate that these approaches may be preferable to individual treatment. A group therapy has the advantage of encouraging multiple diluted transferences in order to deal with the borderline personality disorder individual's tendency towards intense relationships. This reduces the risk of regression within the treatment and also within the treatment relationship. It also reduces the tendency towards therapist countertransferences, either of the rescuing or of the rejecting kind. For similar reasons, family treatment may at times be preferable to individual treatment. In the family situation, it's likely that the borderline patient's intense transferences will be directed to other family members, allowing the therapist sufficient neutrality to interpret these transferences as they arise. The tendency in individual treatment is for the patient to develop such strong transferences to the therapist that the interpretations are only heard within that transference distortion and not heard as being neutral and independently helpful. There are many competing views concerning the optimal individual treatment for borderline patients using the methods of psychodynamic psychotherapy. Expressive psychodynamic psychotherapy for borderline personality disorder focuses on the interpretation of negative transferences, angry impulses, and primitive defenses such as splitting, projective identification, primitive idealization, and omnipotence. This is an intense exploratory and confrontive psychotherapy that requires several sessions a week for many years. The therapist attempts to maintain technical neutrality and does not foster a real or supportive or structuring relationship with the patient. If such relationships are necessary, a co-therapist may be added in order to provide them. This treatment differs from psychoanalysis in its systematic avoidance of transference regression. Its emphasis on clarification and confrontation rather than interpretation, and a predominance of here and now interpretations rather than the reconstruction of the past. It is suited only for the highly motivated and relatively good prognosis borderline personality disorder patients. In cases where self-destructiveness is a concern, as is likely with many DSM-III defined borderline personality disorder patients, external structure may become necessary in the form of hospitalization, day hospital, or adjunctive, reality-oriented supportive sessions with another therapist. This kind of intense, expressive, one-to-one treatment is a high-risk but high-gain choice that should be reserved only for a selected group of borderline personality disorder patients and should be performed only by therapists who have been specifically trained in this and have some sense of how to go about dealing with the pitfalls. Others have argued that this confronting therapy with borderline personality disorder patients may just not be worth the risk. It's an endeavor that has a considerable likelihood of seriously destructive transference regression and acting out. And certainly my experience has been to see many patients who seem to be casualties of intense psychotherapeutic relationships. An alternative therapy is one that is reality-oriented, supportive, and focused on current practical problems in order to undercut rather than interpret the patient's extremes in affect and behavior. In this kind of therapy, more emphasis may be placed on the empathic, supportive features of the relationship than on the content of the transference interpretations. And the supportive and reality-oriented approach is much less intense and confronting than the expressive treatment described just a minute ago. In this treatment, the therapist emphasizes the interpersonal steadying aspects of the relationship with the patient. The therapist is comfortable giving direct advice rather than attempting to interpret the conflictual causes for the transference distortions. In some cases, brief psychotherapies which are targeted to a particular symptom may be very useful with borderline personality disorder patients. Treatments that have more ambitious goals seem likely to raise false hopes and temptations in the patients. When previous treatments have done more harm than good, a brief treatment with very limited goals and specific targets, or no treatment at all, may occasionally be the best prescription for the patient. Cognitive behavioral therapies may teach the patient that there are many shades of gray and that strong opposing views require synthesis. The patient may also be taught less self-destructive ways of dealing with powerful affects and impulses. And we're going to talk about some examples of this later on in the fourth tape. Ways of dealing with a borderline patient who has self-destructive impulses. There are really no control studies to guide the therapist as to the optimal treatment decision for borderline personality disorder patients. The borderline personality disorder criteria set in DSM-III selects an especially heterogeneous group of patients who are really unlikely to respond uniformly to any one particular intervention. And these are difficult patients who are often non-compliant to medication and antipsychotherapy and are prone to overdose on both. Uncovering approaches are probably best reserved for those patients who have considerable psychological mindedness and motivation, and for those therapists who have a great deal of experience in the method. For most patients, a reality-oriented approach combined with medication for target symptoms seems to make the best sense. Hospitalization has the considerable risk of promoting regression and teaching the patient new forms of psychopathology. Extended rehabilitative hospitalizations or day hospitalizations in specialized units designed especially for the treatment of borderline personality disorder may provide the necessary structure for an intensive, life-changing experience. Acute brief hospitalizations to reduce suicide risk and to treat decompensations are sometimes necessary, but these are usually best kept as brief as possible. Therapists often develop strong countertransference to borderline patients, including feelings of rage, dread, guilt, inferiority, love, sexual attraction, nurturance, and pity. The patient's tendency to actualize rather than analyze the transference will lead the therapist to lose neutrality and at times question his or her usefulness and understanding of what is transpiring. Consultations with other colleagues, often with the patient actually seeing the other colleague, may help to provide reality corrections for both the patient and for the therapist to these transference and countertransference distortions. These are tough patients and we all need help with them. The antisocial personality disorder is actually one of the most interesting and controversial of the DSM-III personality disorders. The controversy stems in part from the fact that this is the most reliable of the diagnoses included within Axis 2 of DSM-III. Two clinicians will agree much more readily on the diagnosis of antisocial personality disorder than they will for any of the other 11 disorders that we are going to discuss. And this is a point of considerable pride to some people. However, another group of clinicians and researchers working in this area feels that although the antisocial personality disorder is wonderfully reliable, it misses the point. The basic question is this. The clinical literature on what has been called variously the psychopathic or sociopathic or now the antisocial personality disorder had always emphasized the inability of these individuals to develop loyalty to others, to bond in affectionate relationships, and to learn from past experiences by experiencing a sense of guilt. These features are not included at all within the DSM-III definition of antisocial personality. And the reason they weren't included is because it was felt that they would be less reliable, that it would be harder for clinicians to come to an agreement on their presence or absence. Instead, DSM-III focused on a list of target behaviors that are not very inferential and therefore that are very reliable. These behaviors include things like truancy, lying, theft, vandalism, fighting, impulsivity, recklessness, and poor performance at work, parenting, and in marriage. It's easier to operationalize such things and to get agreement amongst clinicians. The problem is this, though. It's been demonstrated that if one uses the DSM-III criteria in a prison, virtually all of the prisoners, 80% or more, will meet the criteria for antisocial personality disorder. What this suggests is that the DSM-III definition is really a criminal personality disorder rather than an antisocial personality disorder. The distinction may be very important for people working in prisons, where it would be important to know whether someone who breaks the law a lot is capable of loyal behavior or not capable of loyal behavior, capable of guilt or not capable of guilt. It's also been felt that the current criteria are too sensitive to a person's upbringing. The lower socioeconomic classes living in tough neighborhoods are likely to be overrepresented for reasons that have more to do with the social setting than they do with the individual's personality characteristics. So in our current situation, we have a very reliable category, one that may be useful in certain settings, but one that has been criticized for being too narrowly defined and too specific, some people feeling that validity has been sacrificed for reliability. What about the clinical description? The DSM-III antisocial personality disorder individual has a long history of troubles that start before the age of 18. You can't get this diagnosis if you've had a clean, trouble-free childhood. It requires conduct disorder that's really quite severe and of quite an early onset. And there mustn't be at any point in the person's life a period of several years in which such problems do not manifest themselves. So one of the important diagnostic points is, does the person's irresponsible, often illegal behavior have a very, very long and chronic course with an early onset? Or is this behavior secondary to more situational things like using drugs or alcohol and needing money for supplying such substances? Or in relation to Axis I conditions that may be associated with antisocial behavior, especially, for instance, bipolar disorder. Antisocial personality disorder should be reserved for those individuals where the history is unmistakably long and unmistakably continuous. Amongst the Axis II diagnoses, only 2 are consistently found in association with antisocial personality disorder. And these are the borderline and narcissistic personality disorder diagnoses. Now, in some settings, there's very little relationship between antisocial and borderline, and there may be many borderline patients who are not antisocial, and some antisocial patients who are not borderline. But in some settings, and particularly, say, prison settings, there has been quite a bit of overlap. Individuals who meet criteria for antisocial personality disorder tend to have a fairly high incidence of major affective disorder and a very high incidence of suicide, which must be kept in mind in terms of clinical management. And the treatment of the Axis I condition may be much more successful in these individuals than the treatment of the Axis II condition, as we will discuss in a moment. Of course, substance abuse is a frequent, maybe ubiquitous, almost ubiquitous, comorbid Axis I condition for patients with antisocial personality disorder. These are often tough folks to interview, and the ability to make the diagnosis may depend a great deal on accessory information that's available to the clinician. So that if a psychiatrist or a psychologist walks into a prison cell and has before him the individual's records, it may be quite easy to make the diagnosis based on what is rendered during that interview. However, such individuals are often able to hide their previous criminal history in a way that will make diagnosis difficult. And so occasionally a clinician will miss the diagnosis, partly because the patient may be quite skillful in making the manifestations of it quite subtle in the interview situation. The major problems in treating antisocial personality disorder have been documented over and over again. A very large number of programs have been developed, both within correctional and psychiatric settings, intending through one or another means, in some cases psychodynamic, in others behavioral, in others the use of psychopharmacologic interventions, to reverse this very destructive and self-destructive pattern of behavior. One cannot be optimistic about the results. I think basically it's fair to say that there is no treatment for antisocial personality disorder, that we can treat certain target symptoms that sometimes present along with antisocial personality disorder, but the underlying problem itself is probably most often proof to treatment, although some individuals tend to grow out of it with time. There are a number of studies that indicate that increasing age results in a reduction in the prominence of the psychopathology, partly because of selection bias. Some of the individuals wind up dying in one way or another, but partly it seems that patients do burn out and become mellower as they get older. Various treatments have been tried and may be helpful for conditions that are associated with the antisocial personality disorder. A wide variety of medications have been suggested. These include stimulants, antiepileptics, lithium, propranolol, and benzodiazepines. The available research has typically focused on the more affective and impulsive symptoms that are present in some such patients, particularly aggression. There are no data to suggest that pharmacotherapy is effective in the development of a sense of loyalty, but there are some data to suggest that it may be effective in reducing violent and impulsive outbursts. Psychotherapies are generally effective only if the patient is in a setting where there is no recourse to avoid them, and often this means a correctional setting. There's typically little motivation for change within antisocial personality disorder individuals in other settings, and there must be some external leverage and pressure that brings him or her into a meaningful contact with the treatment environment. Quite often, a system that uses peers who've been through the mill themselves and now act as co-therapists has been most helpful, and this has been particularly used in programs that deal with antisocial personality individuals who also have drug and alcohol problems. Family marital therapy is often recommended, at least as an adjunctive treatment, because family members sometimes may support the patient's antisocial behavior, and because the patient's alliance with the family is likely to be much stronger than the alliance with the therapist. In addition, family members are often adversely affected themselves by the patient's behavior and may need to learn how to protect themselves. Behavioral techniques have been recommended, particularly the use of token economies, assertiveness training, and education concerning the consequences of antisocial behavior. The effectiveness of these approaches may be secondary to their occurrence within a residential setting, and it's very unclear the degree of recidivism once the patient leaves that setting. However, a cognitive behavioral approach that appeals to the patient's self-interest in order to motivate more adaptive behavior may be the best that's available under such circumstances. If an individual meets criteria for major affective disorder, it makes great sense to treat that major affective disorder. Similarly, if they meet criteria for substance abuse, great sense to treat the substance abuse, because the comorbidity of antisocial personality with affective disorder and with substance abuse together is a high risk factor for suicide. And so even if we have modest goals about the personality disorder, this shouldn't discourage us from treating the Axis 1 condition that may accompany it quite aggressively. A crucial point to keep in mind with antisocial personality disorder is that it's a great mistake for the mental health system to bite off more than it can chew or claim that it can do more than it really can. Lawyers and judges and policemen are all too happy to have an antisocial individual sent to a psychiatric hospital. Often in the psychiatric hospital, such an individual becomes a wolf amongst the sheep, impossible for the staff to handle, often preying upon the weaknesses of the other patients in the setting, And the problem becomes worsened rather than improved if the individual feels that taking on the sick role will allow him or her to avoid the legal consequences of their actions. It may actually reinforce antisocial behavior. So it's important for the mental health system to make clear what we can do and what we can't do, and not take it upon ourselves to provide treatment in the many situations for such individuals for which no treatment is really available or indicated. There are typical countertransference reactions to individuals who meet the criteria for antisocial personality disorder. One can be made to be excessively gullible or excessively suspicious in dealings with such individuals. There are some therapists who develop fantasies of rescue and believe that if only the misunderstood individual is treated with love and respect, all will end well. Such innocence is usually disappointed, and therapists who begin with that kind of gullibility often go on to be the bitterest and most suspicious in their future dealings with antisocial individuals. The other side of the coin is to not believe anything the patient says, and maybe to carry over with some experiences with antisocial individuals to other patients where such feelings are much less reasonable, so that a therapist can't really be a district attorney questioning every aspect of what the patient says. On the other hand, a therapist can't be a fool. A way of establishing the closest thing to a therapeutic alliance with such an individual is to make clear fairly early on that one expects to be taken in. The fact that one is admitting to vulnerability in this regard means that once the patient takes you in, it's something that you haven't really been surprised about, and you've almost predicted it, so the patient feels less power over you and feels that you're less of a jerk than if they're taking you in and you're not even aware of it. A stance that doesn't promise more than can be offered, that doesn't expect more from the patient than the patient that can deliver, but on the other hand expects as much from the patient as the patient can deliver, that's straightforward and honest, is probably the best stance. But in most instances, whatever the therapist does is going to be ultimately inadequate and unsuccessful.
This ends the side. On this side, and the beginning of the next cassette, Dr. Francis presents 3 longitudinal case studies. As part of the program, you are invited to take a self-test during each, indicating your diagnostic impression and treatment plan. Indications are given during each case when you should stop the tape to enter your impressions in the manual which accompanies this program.
Thus far, we've discussed a number of the diagnostic and treatment issues that cover all of the personality disorders, and then in detail we've discussed each of the 11 DSM-III personality disorders and a 12th masochistic personality disorder that may appear in the DSM-III revision. Some of this may have seemed kind of dry along the way because there's nothing like case material to enliven the discussions. And this tape will be devoted to the presentation of several different patients. In each case, after the presentation that describes the patient's history and current situation, we'll provide a DSM-III 5-axis diagnosis, discuss some of the differential diagnostic issues, and then provide a summary of the various possible treatments that might make sense for each situation. Let's begin with Miss C. Miss C is a 24-year-old woman who looks like she's only 16 and sometimes acts as if she were 3. She can be tempestuous, fickle, manipulative, impossible to please, and convinced that others are never doing enough for her. She becomes easily frustrated, especially in romantic relationships, and has already made half a dozen casual suicide attempts, so far with no harm done. Although she is highly intelligent, makes a good first impression, and can be a very efficient worker, Missy's performance in school, work, and therapy has been characterized by fits and starts. She is a college dropout and went through 3 different preparatory schools. She is working now far below her station, as she puts it, as an office temporary, partly because she's been fired from several different jobs for insubordination. She doesn't feel that she can work at any one place and at any one thing for very long without becoming bored. She has been in and out of all sorts of psychotherapy since she was 17 years old, so far without showing any benefit at all. Miss C's course is characterized by periods of relative steadiness, punctuated by storms that are occasioned by her overreaction to the frustrations of everyday life, particularly the romantic ones. Between storms, she can be reasonable and responsible, but, as she puts it, when she loses it, all hell breaks loose. Her strong negative emotions, particularly anger, crowd thoughts out of her mind, and she becomes desperate and impulsive and must take action, often self-destructive action. Miss C is seen now because she is disappointed in her current therapist. She never wants to see him again and is contemplating suicide. She had begun treatment with this therapist several months ago and was initially very impressed with his manner and appearance. She seemed to be settling down and doing quite well in the sessions. 2 weeks ago, however, she learned through a friend that her therapist was married. In the next session, Miss C felt that her therapist seemed much less attentive to her and did not smile at the end of the session. She felt very rejected and angry and became convinced that he was, in her words, just like the others, an uncaring son of a bitch. She went home and told her boyfriend that she was going to kill herself because, again in her words, there is no love in the world. Miss C has never experienced mania, hypomania, or depression that has lasted sufficiently long to qualify for the diagnosis of major depression. Her downs generally last only a few days and disappear, again in her words, after I've blown off steam or when something interesting happens or someone interesting asks me out.
Stop the tape now and enter your diagnostic impression in the manual.
Let's go through the 5-axis DSM-III diagnosis for Miss C. Axis 1, Miss C would qualify for the waste paper basket diagnosis atypical depression. Some people would call it hysteroid dysphoria. She does not satisfy the criteria for any of the clear-cut depressive disorders and has a course that's characterized by frequent short bouts of depression which are very reactive to frustrations and can be improved when external circumstances brighten up for her. Her Axis 2 diagnoses would be borderline and histrionic personality disorders, and we'll come back to that in a minute. She has no diagnosis on Axis 3. On Axis 4, her diagnosis for stress would be none. These episodes occur really with mild or minimal stress, and there is no stress directly related to her current request for consultation. Her highest level of functioning in the past year could be characterized as fair. She has major impairments in her work and in her social and love life. Well, what about the personality disorder diagnoses? In what way does she meet the criteria set for borderline personality and for histrionic personality? She has many of the criteria that are included in the set for borderline personality disorder. A pattern of unstable and intense interpersonal relationships with alternating periods of extreme idealization and devaluation. She's interpersonally exploitive, taking advantage of her boyfriends. She's impulsive in many areas of her life, especially substance abuse, sexual activities, and self-mutilating behavior. She has marked shifts in her mood, an inappropriate, intense anger that's characteristic of her long-term functioning. She makes recurrent suicide threats, and although it's not clear in the record, it's likely that she has persistent identity disturbance. A number of commentators have noticed that there's a good deal of overlap in the criteria sets for the borderline and for the histrionic personality disorder, and several empirical studies have demonstrated a good deal of overlap. Miss C meets a number of criteria for the histrionic personality disorder. These include her dramatic speech, her constant seeking of reassurance and approval, her sexual seductiveness, her concern, or perhaps over-concern with her physical appearance, her exaggerated expression of emotions, her discomfort in situations in which she's not the center of attention, her egocentric and self-indulgent behavior, and the fact, not mentioned in the case history, that she's perceived by others as shallow and lacking in genuineness. What are the treatment options for Miss C?
Stop the tape now and indicate your treatment plan.
Indeed, she is a scarred veteran of many previous treatments and presents now precisely because she is unhappy at what she perceives to be the ending of her current psychotherapy romance. The first task of the initial consultation is to assess acute suicide risk and the need for hospitalization. Hospitalization of patients like Miss C has the possible advantages of reducing the risk of suicide and of confronting her with the seriousness of her suicidal behavior. It has the possible serious disadvantages of promoting further regression, providing Miss C with new models of psychopathology with which to identify. She's likely to learn new and better forms of psychopathology from the other patients with whom she'll be living on the inpatient psychiatric ward. Finally, another disadvantage of hospitalization is the possibility that it will reinforce Miss C's manipulative suicide behavior as a means of escaping from difficult situations. Generally, if the suicide risk is relatively low in borderline personality disorder patients, I will recommend the opposite of whatever it is that the borderline patient appears to want. That is, I will not hospitalize those borderline patients who are trying to use hospitalization for secondary gain, and I will hospitalize those borderline patients who really don't want to be in the hospital and who have been treating suicide as a kind of casual game. The next question in the consultation is what form of therapy is likely to benefit Miss C, and with whom. Specifically, is her current transference storm to be ridden out, or is it better that she be referred to another therapist? Should medication be prescribed, or should a recommendation of no treatment at all be made? Miss C's diagnosis and past performance in treatment make it clear that she is a difficult and treatment-resistant patient who is likely to repeat in the transference the cycle of unrealistic hope and excessive disappointment that has governed her life outside of treatment. There is no magic in these situations, but a few suggestions may be helpful. I would go over with Miss C in careful detail just how repetitive is her pattern of behavior and confront her with the fact that she is now repeating with her current therapist the very same drama that she has automatically followed over and over again in her life. I would point out that this is a common enough problem, especially among young single women, but that it reflects an immaturity and overreactiveness in her character that she should try to outgrow. I explain that the only risk in her situation as it now stands is that she will inadvertently or advertently hurt herself, and that this will occur before she has had an opportunity to experience enough of treatment and of life to gain a more even keel. Borderline patients often respond surprisingly well to this sort of direct, counter-regressive, structuring confrontation, and at least for a while become more serious and cooperative in planning their treatments. Often the best work is done right after a storm, preparing the patient for spotting and reducing the intensity of the next storm. We don't have time here to discuss all of the advantages and disadvantages of all of the various treatment options that are possible for Miss C, but I will outline these briefly. Miss C might return to her therapist or be referred to a different therapist, perhaps a woman, in order to continue within a psychodynamically oriented treatment with the goal of increasing her understanding and control over the conflicting wishes and fears that prevent her from developing a cohesive sense of self, and to help her improve her coping with the psychological stressors that trigger her erratic behavior. It's often useful to be very attentive to the specifics of the patient-therapist match, and some borderline personality disorder patients who do dreadfully with one therapist may settle down and do just fine with another. The cognitive behavioral approaches address themselves to specific symptoms, behaviors, and thoughts evidenced by the patient. Just to give one simple example, it's often useful to advise a self-mutilating borderline personality disorder patient to squeeze ice or to keep her hand in ice water until it really hurts, in order to counteract the desperate tension such people feel. This can substitute for the patient's tendency to use self-destructive wrist slashing for the same purpose of counteracting the desperate tension. Although Miss C does not meet the classic criteria for affective disorder, monoamine oxidase inhibitors may be useful in reducing her dysphoric outbursts and in promoting her cooperation in therapy. A number of other medications of all sorts of classes have been used in borderline personality disorder patients, but thus far the specific indications for these medications are unclear. Instead, it's wise with personality disorder patients to treat target symptoms rather than to expect that any medication will be specifically useful for the personality disorder itself, so that to the degree that there are affective symptoms, the use of antidepressants or in some cases lithium may be advised. Various combinations of the various psychotherapeutic and somatic approaches may be optimal for many of these patients. The importance of a stable, structuring relationship, however this is maintained in the face of numerous challenges, should not be underestimated. Other treatment possibilities that are sometimes helpful include brief therapy targeted to a very specific and solvable problem, family management, and group psychotherapy. Brief therapy is useful because it can give the patient a sense of treatment working well in one particular area and because it tends to reduce regression within treatment. Family and group treatments reduce transference over-involvement with the therapist and also reduce the countertransference over-involvement that many therapists have with such patients. The prescription of no further treatment at this time should also be seriously entertained as a possible recommendation and perhaps discussed with Miss C. She has thus far not benefited in any demonstrable way from treatment. In fact, she involves herself with therapists in a way that seems to promote rather than reduce her suicidal risk. It is also possible that she feels less motivation to control her change her behavior while she is within the regressive, that is for her regressive, protection of a therapy meant to understand it. Treatment may provide temptations that cost more than it is worth. The patient can be advised that a trial of life on her own may have the same benefits as are often realized when one moves away from home to fend for oneself. The trial of no treatment can be relatively brief, 1 to 3 months, to be followed with repeated evaluations to determine how well it has worked out. Well, let's go on to the case of Miss B. Very different sort of situation. Miss B is a 35-year-old businesswoman who presents with panic attacks of 2 years' duration. These are characterized by rapid onset of shortness of breath, palpitations, dizziness, tingling in her fingers, fears of going crazy, and a sense of unreality, the usual symptoms of a panic attack. The episodes last for half an hour, occur several times a month, and are especially likely when Miss B feels threatened by rejection or by obligations, such as speaking on the telephone, going to parties, dating, meeting job deadlines, and when she visits her parents. None of these situations consistently results in panic, and some episodes occur out of the blue. Since her recent promotion, the frequency of the attacks has increased to several times a week. She's begun spending 14 hours at her job, but feels that her anxiety about it is making her indecisive and reducing her efficiency. She worries constantly that her incompetence will be discovered and that she will be fired. She also hates her boss and believes that her boss hates her, despite the fact that he recently recommended her promotion. Miss B is a very lonely and isolated woman who avoids close relationships because she is afraid of being criticized, rejected, and or burdened by other people's problems. She felt that she was prematurely forced to care for her agoraphobic mother and has resented demands that were made upon her by others. Miss B previously avoided seeing a psychotherapist and hates doing so now because she is convinced that they were never able to help her mother and cannot now be helpful to her. She comes now for consultation only because her symptoms are getting worse, and she's been reading articles in newspapers and magazines indicating that new methods exist for treating panic disorder. Nonetheless, she appears to be an unwilling participant in the evaluation process. She is guarded, mistrustful, and frequently replies to questions with, "Why do you need to know that? Don't be nosy." She seems sensitive to criticism and concerned that the therapist is trying to expose her weaknesses. At the beginning of the second consultation visit, Miss B states that she thinks treatment would be a mistake at this time and that she would like this to be her very last visit.
Stop the tape now and enter your diagnostic impression in the manual.
Miss B's DSM-III diagnosis on Axis 1 is quite straightforward. She has the classic signs and symptoms of a panic disorder. On axis 2, she meets criteria for both avoidant and passive-aggressive personality disorders. On axis 3, she has a mitral valve prolapse, which is a not infrequent concomitant of patients with panic disorder. On axis 4, her stress might be considered moderate, the promotion at her job. And her highest level of functioning on axis 5 would be considered good. The criteria for avoidant personality disorder met by Miss B would include no close friends or confidants outside of relatives or members of her household, her feelings of being easily hurt by criticism or disapproval, which have surfaced even within the context of the consultation itself, her unwillingness to get involved with people unless she's certain of being liked, and that includes the therapist, her avoidance of social and occupational activities that involve important interpersonal contacts. Her problems with the promotion illustrate this, and the fact that she's so afraid of appearing foolish or being embarrassed. Miss B also meets the criteria for passive-aggressive personality disorders. In DSM-III, this diagnosis is meant to be given only if other diagnoses are not present. This exclusion will not be present, however, in the DSM-III revision, and one can use the passive-aggressive personality disorder diagnosis along with any other personality disorder diagnoses that are met. The criteria for the passive-aggressive personality disorder met by Miss B include the fact that she tends at work to put things off and procrastinate a lot, that she protests that others are constantly making unreasonable demands on her, that she becomes sulky and irritable and argumentative when asked to do something that she doesn't want to do, that she thinks she's doing a much better job than others appreciate, that she resents suggestions made by her boss and by the therapist about how she might be more productive both in the treatment and in her life, and that she's unreasonably critical or scornful of the people around her. This came out most clearly in her descriptions about work, but is also beginning to emerge in her descriptions about the treatment.
Stop the tape now and indicate your treatment plan.
There are any number of very effective treatments for panic disorder, both psychotherapeutic, psychoeducational, also medication treatments, but that's not our major focus of concern here. Major problem in this situation is the fact that Miss B's avoidance and passive aggressiveness will likely prevent her from any meaningful participation in the treatment. Avoidant patients are often very fearful to start treatment, but once engaged are very eager to continue in it and hard to terminate. The first step in engaging such a patient must include conveying to her an appreciation for how difficult it is for her to begin the treatment participation, a complimenting of her courage in finally being able to bring herself to do something so difficult. Psychoeducation, both about the Axis 1 condition of panic disorder and about the Axis 2 conditions, particularly of avoidant personality disorder, are often very useful in engaging the patient in treatment. It can be made clear to the patient that her pattern of avoidance is responsible both for her current panic attacks and for her long-standing inhibitions, which have made it difficult for her in the past to fully enjoy her life and to have the wide range of interpersonal and professional successes that would otherwise be her share. If the therapist makes clear that there is a treatment that's likely to be effective both for the panic attacks and for the avoidance, and that this treatment will be done at a pace set by the patient, it's very often possible to enlist her cooperation in the treatment. The behavior therapy techniques that have been well described and tested in the treatment of agoraphobia and social phobia are likely to be just as effective in combating Miss B's chronic and characterological avoidant pattern. Assertiveness training is also quite useful. Cognitive approaches are also often useful with avoidant personality disorder patients. These individuals have a tendency to see the worst in every new situation, to be pessimistic, mistrustful, and to have low self-esteem. Just as cognitive techniques can work against these irrational and automatic thoughts and depression, so they can also be applied when these same thoughts appear in patients with avoidant personality disorder. A psychodynamic approach is often helpful as well. In the case of Miss B, her promotion to a new level of responsibility at work was the equivalent in her unconscious mind to having to take care of her agoraphobic mother. This new level of responsibility reminded her of the situation in which demands would be made upon her that she felt she could not meet. The psychodynamic exploration of the feelings evoked by this situation can often help the patient to participate in activities that were previously avoided. Passive-aggressive personality disorder is very difficult to treat, partly because the patient is likely to display the same kind of sullen oppositionalism toward the therapist and the therapy as is displayed in other aspects of life. Behavioral techniques that emphasize assertiveness training have been described for the treatment of passive-aggressive personality disorder. Cognitive techniques are often useful to point out to the patient just how oppositional they are. One of the characteristics of passive-aggressive personality disorder individuals is their inability to understand why it is that other people are constantly frustrated with their performance. Psychodynamic techniques that attempt to understand the reasons for the oppositionalism, and often this has to do with the patient's desire to maintain autonomy in the face of what are considered to be threats to that autonomy, are often also useful. In the case of Miss B, she responded very well to a program of psychoeducation and behavioral therapy for her panic attacks. Her residual personality traits of mistrust, oppositionalism, pessimism, and low self-esteem were more difficult to deal with within the cognitive behavioral model, and she entered into a psychodynamic psychotherapy at the end of the short-term behavioral treatment. The goals of this therapy were to understand the underlying conflicts that resulted in these personality traits, and 3 years down the line she's really improved a great deal in the Axis II diagnoses.
This ends Tape 3.